I'm Mark Juan. We have just announced 73 contestants who are advancing to the next round. Congratulations to all of you. You should be very proud. During the next 4 consecutive weekends, we will broadcast top 10 presentations of the round 1, the National League competition. We wish we can upload all 73 presentations because they were so good, but we can only have time for limited numbers. Starting this weekend, we have 3 of the top 10 presentations from North America and Australia region, each representing their own countries.
Hi, the presentation you're about to watch is entitled Putting the Fun Back into Fundamental. This was a presentation by aspiring dentist Dr. Andrew Ip from Marsfield, South Wales, Australia. I thoroughly enjoyed this presentation for many reasons. Firstly, Andrew's topic was inviting, relatable, and relevant. The title says it all. By electing this topic, Andrew was able to relate to both beginner-level dentists as well as veterans. He unpacks how employing the latest technology into our world of implantology can vastly improve the care we offer our patients. Bravo! As Andrew unpacked his presentation, there was no doubt in my mind that Andrew is vastly knowledgeable about this topic, and that he has indeed practiced this presentation many times. He thoroughly, but not exhaustively, executed the presentation each time, clearly highlighting the case complexity where needed, including key documentation to make his case, with detailed quality photographs, radiographs, and imagery. Andrew also cited relevant supporting research to support his case in a digestible manner. Lastly, Andrew presented himself confidently. He was relatable as a clinician. His delivery was easy to listen to, with each step making me, the audience, wanting to track what he had to say and more, all the while falling clearly within the 15-minute presentation time limit. It was apparently clear to me that Andrew has invested himself into rehearsing this presentation many times. So Andrew obviously left a very good impression on me. He made the presentation personable and relatable. Could there be improvements? Certainly. Such as Andrew's delivery, he could convert his presentation into one that is more storytelling, one that would stick to the mind of the listener better. Nonetheless, Andrew delivered a presentation that was well received by me. I would like to take this opportunity to share with you the presentation I've had the privilege of listening to, Putting the Fun Back into Fundamental, how 3D printing can enhance patient outcomes in basic dental implantology. Enjoy.
I'm excited, and
I'm excited too.
yeah. So I'll leave it to you, Andrew. When you're ready, the moment you begin speaking, I will then start the timer.
Okay. Well, let's get started. G'day, everyone. I'm Dr. Andrew Ip, and today I'm going to go through a nice simple case with a little bit of a digital twist. So I'm sure today both of you have seen a lot of nice complicated cases, hard tissue grafting, soft tissue augmentation, all on X cases. But I'm going to actually take a step back, and I'm going to actually go through quite a simple case that one would encounter in many general dental practices. But I'm going to add a little bit of a digital twist to it. So I hope you all enjoy my case. So a bit about me. I'm a general dentist based in Sydney, Australia. Of course, you can see my boring list of credentials there, and I'm a 3D printing enthusiast. I've used numerous 3D printers in the past, and I think my tally now is hitting about 17 printers that I've used. But these days, I limit myself to just a couple of resin printers. I'm also using an FDM printer, which is a filament printer, and I also do have a ceramic printer. So I've been teaching dentists and dental technicians for about 3D printing for quite some time now, several years. And what started off as a hobby has now become an integral part of my general practice. So when we think about 3D printing, we often think of these small little toys, miniatures, little bits and gadgets and gizmos. So that's basically where I started off. But these days, 3D printing in dentistry is a huge field. It's really booming. I think in RDS in March, I think there were over 600 exhibitors showing some sort of 3D printing related products. So as I mentioned, I started off as a hobby, and I started printing things like this, small little miniatures, helmets for my cats, right? And yeah, you can see, like, I just realized, hey, I can bring this into my practice. So these days, most of the printing that I do is actually for work. So unfortunately for my wife and my cats, I bring all of my work back home. And this is an example of what I've been doing for the past few years. These are a set of long-term provisional veneers. They're a resin called Crown Tech. Now I've just polished them. I haven't glazed them at all. And I'll show an example later in this presentation. So suffice to say, this is my reality now, my existence. I spend a lot of time on my printers, a lot of time on resins and materials, and of course, a lot of time on my cats. They live a very, very, I guess, pampered life. So let's meet the star of our show, our superstar patient, okay? So we have a 22-year-old female who is medically fit and healthy, no known medical issues and conditions. She's missing a lower right molar, which has been endodontically treated, but she's lost it because of vertical root fracture. Now, she's young, she's bubbly, she doesn't want to wear denture, she doesn't want to go out and have to worry about something falling out, or she doesn't want to take it out just before she eats. So a denture's just not it's something that she's going to consider. She's also not considering a bridge. She doesn't want to touch any of her adjacent teeth. She's had a lot of work. She's gone through the whole root canal process, crown process, and it's not worked out for her. So she's not keen on affecting her or involving her other teeth. So as a result, she's going for an implant and a screw retained prosthesis. Now, you can see on the X-ray that there's adequate vertical height for a 10 millimeter implant. And later on, when I show you guys the cone beam CT, there's adequate height and width for 4 by 10 millimeter implants. Now, you can see in the photographs, there is some hard and soft tissue loss, particularly buccally, which is a very common pattern that we see in these lower molar cases. So what are we going to do? What is our plan of action? First, we're going to plan her case on Blue Sky Plan. Then we're going to design a surgical guide after planning her treatments and produce a surgical guide. We're going to print this guide on the Sprint Ray Pro 95S out of surgical guide resin. We're going to confirm the fit of that guide. And then after all of that is all good, we have the green light to finally place her implants. And this is a case that any general practice will encounter and can certainly achieve. So let's run through this video. Now, the implant system that I'm using is called TriMatrix, and it's a relatively new system in the market, but I'm a big fan of this system because it's got a really strong digital focus. Now, as a user of this system, I have access for free to a full suite of digital healing collars, which I can edit, which is what I'm doing right now, and then subsequently I can print it or mill it. Now, you notice initially at the connection, those angles are quite straight. And in my opinion, I always like to make my my angles a bit more concave, so you can have that soft tissue infiltration into those areas. And that's basically what I'm doing here. I'm using software. This is the Medit Design app, which is free for anyone to use. You don't need to use a medic intraoral scanner, but you can still use the software. And I'm just basically adjusting and changing the connection to the way that I want it. And you'll also notice that the connection is completely round. Like there's no sharp edges, and that's specifically because they've designed the system in such a way that it can be printed, but also milled, because sharp edges are quite challenging to mill properly, even in a 5-axis mill. So this is why I like this system, and we're going to export this file, and then we're going to print it. Right. And I'm going to print it in 2 material options. First is onyx, which is a hybrid ceramic material. It's a temporary material. And the great thing about printing is that you can print all of these babies in one go, because the height of the print is what determines your duration. So you can see these are fresh out of the print. Now, obviously, we can't use these yet. We have to wash them. So this is how they look like when they're fresh out of the printer. And then we have to wash it in isopropyl alcohol. And then we cure it, just like we cure our composites. And I'm using Sprint Ready Pro Cure 2, which takes about 5-10 minutes for it to cure. And it's really important that we follow these steps, because we are putting these things in people's mouths, and they must follow a validated process. And now, as I said, we're printing these out in zirconia. So we're not milling, we're actually printing these out. Now, this is the Zipro D. It's a dental specific ceramic printer. So it prints out green state zirconia. So after these are printed, you need to sinter them in an oven or furnace. But why zirconia? I mean, why not use something else? Well, I'm a big fan of zirconia because you can polish it up to a really, really nice mirror shine, as you can see here. And it's fantastic for the soft tissue. So back to our case. Lower right missing molar. We're planning the case on Blue Sky Plan, which has over 70 implant systems on it. So yeah, I really, really enjoy how great and easy it is to design and plan my implant cases. And here's the guide, and we're going to export it and print it. Once again, using Sprint Ray, using Surgical Guide 3. And I love this Surgical Guide resin because when you put it in the mouth, it's very clear. It's quite transparent. And yeah, that's basically what I've done after the healing collar's been placed. All right, so let's take a step back before we look at the results. Why did we go through all of that hassle and that trouble? Why not, just place an implant freehand and just use a stock healing abutment? What are the reasons behind the decision-making process? Let's go through them. Okay, so why zirconia? First of all, there's some evidence to show that zirconia leads to a better cell response. De Cruz and his team published a paper in 2019 showing that there was better fibroblasts and osteoblasts adhesion to zirconia when we compare that to titanium. Nikovicius, another big name, concluded that zirconia leads to better soft tissue, or what we call pink aesthetics, which is particularly important. I mean, not particularly in this case, but in other cases where we have a thin gingival biotype, especially in the anterior maxilla where the patient has a high smile line. Because zirconia can be polished to a really, really fine and almost like mirror-like shine, Beans and his team showed that polished zirconia could lead to lower plaque and bleeding stores, which is fantastic. There's growing evidence to show that soft tissue loves polished zirconia. And then why guided surgery? Why not, do it freehand? Well, we know that guided surgery can provide great accuracy and precision in many uses. I prefer to use a pilot guide because I like to have that degree of maneuverability, that flexibility during the implant surgery. You don't know what's going to happen once you open that flap, right? Whereas for a fully guided system, I mean, you better hope that your imaging and your planning is perfect. I think for less experienced implant surgeons, surgical guides are a great tool. Now, they're not going to replace, skill and experience, but they're a great tool, especially when you're starting out. But I wouldn't always rely on one. I think the hidden benefit of planning and making your own surgical guides is that you really know your cases back to front. Okay. Look, when I plan my cases, I know the anatomy. I know what to expect once I open that flap. That type of knowledge can only come when you actually properly study your own cases adequately. So let's look at our results. Now, as you can see, great soft tissue profile, considering that we didn't do any extra soft tissue surgery. All we used was a semi-customized healing collar, and I did place a little bit of alloplast buckling, just not to augment the bone, but just to preserve that soft tissue contour temporarily while we're waiting for everything to heal and mature. But there's no soft tissue surgery, nothing from the palate. I haven't do any of that. All right, and some more images of the before and after. So I know for sure that the implant threads are completely embedded within the bone as I placed it within the bone. Of course, we do anticipate some of that alloplast to resolve with time, but as I said, I'm not terribly concerned about that. I only really place that there as an optional step to really bulk out and preserve that soft tissue contour, as opposed to actually regenerating hard tissue. So, what can we take from this case? What have we learned about this very simple and fundamental case that we can encounter in any general practice? Look, I've learned that even the simple cases can benefit from digital dentistry. Good planning is an excellent way to know your cases in detail. If you fail to plan, you're really planning to fail. It's just a matter of time. Sure, you may get lucky up to a certain point, but if you don't plan and study your own cases, really you're setting you up for failure. I plan and make surgical guides for all my cases, whether it's a single unit posterior or whereas multiple units. I do my own planning, and it really forces me to study my cases in detail. Of course, as a 3D printing enthusiast, 3D printing has opened up, some great applications in dentistry as a whole. And really, it's just the limits are just, limited by your imagination and your time. So I'd like to really conclude my presentation. I hope both of you had, took something out of my presentation. I know I certainly learned a bit covering all of this. And I hope, I'm sure you've seen plenty of cases that you took a thing or two back home. And if you don't 3D print, I certainly would highly recommend getting into it.
Thanks a lot, Andrew. That's amazing.
Thank you.
Hope you found it a little bit interesting.
It was, yes. I thoroughly enjoyed it. Thank you.
Cool.
Yeah, it was wonderful to hear. Thank you very much.
Yep.
Obviously, I cannot give you any further feedback. We'll be doing our grading, and stay tuned.
The presentation you're about to watch is titled Rethink Implants and GBR by a young aspiring dentist from Washington, D.C., USA, Dr. John Koo.
I really enjoyed his presentation for several reasons. First, his choice of topic was simple yet relatable. Rather than sharing really complex, difficult, fancy case, I think Dr. John Koo deliberately chose a topic which most of the beginner level dentists can all relate to and oftentimes find themselves in decision dilemma. When I watched his presentation, I immediately realized that he's a pro, a professional. He might be first timer on Megamind competition, but I can tell that he teaches frequently. The way he documented his photos, research supports, and the way he carries himself on the screen was flawless. Another reason why he scored very high was that he knew how to score points. What I mean by that is that he was able to satisfy all the categories: case complexity, research support, documentation, and delivery of the story. And he did all that in 15 minutes sharp with surgical precision, no pun intended. Obviously, he prepared diligently and rehearsed many times. This guy really impressed me. Only thing I feel that the presentation was lacking was a strong ending with a memorable storytelling. If he keeps up the effort and make few tweaks, I think he might go very far in the next round. No further ado, here's Dr. John Koo, Rethinking Implants and GBR. Enjoy.
Well, Dr. Jen, thank you for taking the time to listen to my presentation tonight. Like you know, my name is Taesung John Koo. I go by John. I graduated from Tufts Dental School in 2015. And currently, I own my own private practice in Washington, D.C. since 2017. And tonight, I am excited to invite you to rethink implants and GBR. So in this presentation, I will go over a case where implants and GBR were done simultaneously. I will also discuss supporting research and literatures, and I noted the citations at the bottom of the slides. This is Justin. He is a 49-year-old male. One thing to highlight on his medical history is that he is an HIV positive patient, and he is taking a combination antiretroviral medication to treat the HIV. So a little more precaution was taken during the whole part of surgeries. As far as dental history goes, patient reported that he had previous multiple cracked fillings to crowns and failed root canal treatments, which led to extractions and implants in the past. He also reports that he has an impacted tooth on the anterior region with the long span bridge on the maxillary anterior. As far as bite and joint is concerned, he is diagnosed with constricted chewing pattern. These are the series of photos to analyze his patient's smile. Notice that on the repose picture, we don't see any of his maxillary incisal edges at all. And also on the Duchenne smile on the lower left picture, we see very unsymmetrical asymmetry on the gingival architecture as well as a smile line there. Okay. I utilized Coy's reference glasses for dental facial analysis, as well as digital mounting of the case. This is a panoramic image acquired from the pre-op CBCT. There is a lot of biomechanical and periodontal concerns for the maxilla. But the good news is, compared to the maxilla, the mandible shows some signs of wear, but there's no high risk in bio or perio in this case. Back up one there. Overall gingival health is looking good, but around tooth number 6, where there is an open margin on the existing crown, perio pocketing of 6 to 7 millimeter was recorded along with bleeding. Intra-arch space is wide and patient doesn't show any signs of airway issues. Based on the method of facially and prosthetically driven treatment planning, this is a full mouth rehab treatment plan. For today's presentation, we're going to focus on the surgical part of the plan, which is to replace the long span bridge with single crowns and implants. remove the impacted tooth number 9, and we're going to be placing implant on number 8 and 10 sites along with some GBR. This is a CBCT imaging highlighting that impacted tooth number 9. I found this very interesting. You can see the tooth is sitting upside down with the incisal edge pointed towards the nose. And as for me, at least for me, this was the first time ever seeing a tooth pointing in that direction. So I wanted to show this. Now, I will walk you through the procedural details. First, we removed the existing PFM bridge, removed all recurrent decay, scaled root surfaces to remove all calculus, and then refined the preps and made provisional bridge before we started the incision. After the flap was raised, the impacted tooth was uncovered and sectioned into 2 pieces for complete removal. And following the extraction, we can see the extent of the bony defect that was left behind. This 4-wall defect is relatively on a larger scale. Looking at a close-up view, number 8 site had adequate bone for an implant placement at this time. But this defect on number 9, 10 sites, however, would call for a debate by many clinicians as to when GBR needs to take place. Some might argue that GBR needs to be done first in order to have enough bone before placing an implant. I would argue that implant and GBR can be performed simultaneously, and let me talk about why. When it comes to GBR, there are 2 common questions. First one is, how much bone do we have to grow? And second is, which technique are we going to utilize? Right? And the first question of how much bone we need to grow is, I think it's on the more straightforward side. Based on the prosthetically driven plan, you work backwards to figure out how much volume of bone is going to be needed in order to house the titanium screw. And the second question of which technique to utilize is the one that confuses a lot of younger doctors, I think. My philosophy is that there are many ways and techniques that can achieve predictable outcomes, and there is no one right answer, right? So whatever technique that fits the need for the particular case should be just used based on your clinical skills and whatever technique you would like to utilize. Now, let's think about how the native bone versus newly formed bone through GBR come into play. When we do GBR like this, on a deficient ridge like this, when we do GBR, regardless of what kind of technique we're using, are we really making true bone? And do we want to place your implants and rely mainly on the newly formed bone only, right? At least for me, I would prefer rather to have my implant on the native bone as much as possible for a good primary stability. And we all have seen this graph of how the total stability of the implant depends on the primary and secondary stability. Hence, we see the overall stability has this V kind of shape where it dips down at about 4 weeks and starts to come back up as the secondary stability starts to kick in as the body remodels the bone around the implants. But this study was published back in 2005. And since then, we have had hundreds of clinical research and studies published, and they have pushed implant dentistry to advance even further. Many research have shown how the actual implant design can change the outcome. For example, this study by Dos Santos group shows how the geometry of the implant surface design leads to greater primary stability. Based on those findings, some companies took their implant design to the next level. And we all know Megagen is one of them. With this knife thread design, they were able to push the envelope even further and open up more opportunities for clinicians like us. So let's look at this graph a little bit closer. Megagen's AnyRidge overall stability does not have the usual dip on the curve like we saw on the previous curve, and it stays up and only goes up as a secondary stability kicks in. So now with the advancement in implant surface design, we need to rethink the concept of GBR around implants. It's not just regarding Megagen implants, but there are many other systems out there that do provide this primary stability with the better geometry and surface design. So I think it is time for us to rethink about this. And instead of focusing on how much bone we need to grow, we need to shift our attention to the remaining. Is there enough bone now? I place my implants on native bone when I can visually see and confirm the primary stability. That primary stability also needs to show minimum number of 35 newtons in its insertion torque. And that's based on a lot of literature that suggests that's recommended for provisional, immediate provisionalization, and so on. And at the same time, I perform GBR using grafting technique necessary for that particular case, whether it be Curry's block bone grafting or sausage technique or just simple sticky bone, just depends on the case, right? And the newly formed bone through GBR will only add to the overall stability of the implant. There are some other advantages to the simultaneous implant placement with GBR, such as they act as a tenting screw, instead of placing tiny little tenting screws to do GBR first, the implant with the great stability will act as a tenting screw for you. And also minimizes the volume of bone the body needs to regenerate, and shortens the time of the overall treatment because we don't have to do multiple surgeries to stage the surgeries. So instead of the staged approach, I prefer simultaneous approach. And I use this thing called performance enhancing implant accelerator when I do GBR. This is also known as a sticky bone, started by Professor Diaz Son and Dr. Jen Kim. And I can assure you, despite the advantages we gain through all the growth factors, there is nothing illegal about this. Okay. Now, going back to the case. Now the implants are placed. A tenting screw with a wide umbrella was used for added support on space maintenance. And insertion torques and ISQ values were high. So the primary stability of these implants are looking great. And you can also see the implant threads are exposed by design. Flap was raised to achieve tension-free primary closure. And the gap is filled with allograft sticky bone. And pressed PRF was layered over the graft to contour, to cover the full surgical site. Using PTFE and chromic gut sutures to close up the flap for primary closure. And the provisional bridge that was made at the beginning of the appointment is delivered. Now, the immediate CBCT shows satisfactory results. Also, the tenting screw was also well engaged into the native bone for good stability there. At 2-week post-op, we see excellent soft tissue healing. But do you notice tooth number 11? Now, that is a topic for another day, so I'll skip over that for now. At 4 weeks, the site is healing exceptionally well. This is a 3D printed full upper arch provisional. And while the upper anterior surgical site was healing, the full upper arch was prepped and provisionalized at the desired new VDO. Patient presents for second stage surgery at 3.5 months. And we also see nice, thick, attached keratinized tissue present, as well as the volume is being nicely maintained. Another follow-up CBCT. And let's zoom in on the cross-sectional views. And we can see there's plenty of bone formation around those implant sites. Now, during the uncovery, after a full reflection of the flap, there was some soft tissue ingrowth in this area around implant number 10. Looking back, I wish I had used a type 4 collagen membrane. It probably would have helped prevent this soft tissue ingrowth. But after a thorough debridement and removal of the tenting screw, it was confirmed that there was adequate solid bone for me to continue with the case. Also, the ISQ values have gone up since the initial placement, which is always a good sign. So along with the healing abutments, I added more of sticky bone for better contour of the hard tissue in that area. These are a new series of portrait photos of the patient with his new smile. And you can see in the middle repose picture where we didn't see the inside of the latch, and now we're seeing that since we increased the VDO as well. And looking at these before and after photos, I can say the patient and I were both very happy with the results. And with that, I believe my time is up. So thank you, Megagen, for this opportunity to participate and present. And thank you, Dr. Jen, Dr. Louis, for taking your precious time to help the younger generation like myself to nurture and grow. I hope I get to meet both of you guys in person soon. Thank you again.
Albert Einstein once said, "If you cannot explain a concept to a 6-year-old, then you don't understand it yourself." The presentations that impressed me the most were not the ones where the surgeon was trying to impress me with his or her surgical skills. Rather, it was the one where someone would take a simple case and unpack it, tell their story, and made it interesting. I think Scott Jung did just that. Scott is a young dentist from Vancouver, and his presentation is entitled "Leaping into Immediate Implants, Overcoming Fear." This is one of several presentations that left a positive impression on me. Scott's topic was interesting enough for it to be relatable to just about any dentist. Though once a controversial subject, immediate implantology, Scott was able to personalize his presentation. He shared about his evaluation of his own treatment philosophy and the journey he took to incorporate this procedure into his world. Generally, Scott fulfilled each of the 4 categories quite well. He selected an interestingly enough case, one with sufficient complexity, where he provided clear documentation with good quality photos, radiographs, and illustrations, and it enabled me to follow along, especially when he cited research to make his point. Regarding the delivery, Scott wrapped up his presentation in a form of a story. This helped make his presentation memorable, and he did it within the 15-minute time limit. Regarding areas where I believe Scott could improve on, I believe his presentation could be more natural, more confident, and more heartwarming. But overall, I think he did nicely. It is obvious that he rehearsed his presentation many times. Throughout the presentation, I was able to track the content with what Scott was saying, what he was unpacking without distraction. In fact, it was rather personal and relatable. So kudos to you, Scott. Without further ado, I would like to share with you Scott Jung's presentation, Leaping into Immediate Implants, Overcoming Fear. Enjoy.
Good afternoon. First of all, thank you for providing the opportunity of Megamind to allow aspiring speakers like myself to have a platform to stand and present. My name is Scott Jung, and I am happy and honored to be able to participate in this competition for my second time. During the last year's competition, I didn't get so far, and one of the reasons was I was struggling to find the cases to present. And in the busy days of the clinic, it's hard to start to document your case. But since last year, I made my dedication to pick up my camera more and to take more pictures so that I can showcase these to you. And so today, I'd like to talk to you about immediate implant therapy. Immediate implant therapy came with a very steep learning curve, but soon became my very new passion to try to figure out ways to place an implant into a freshly extracted socket. Why do we try so hard? And it's because immediate implant therapy has a lot of benefits that we just simply cannot ignore. And I believe it is our job as doctors to provide the best available treatments for our patients. This is Vancouver of BC, Canada. I am truly blessed to live, eat, sleep, and work in this beautiful city with the vibrant nature and immersive culture. I have two simple jobs here, one as a family man and another as a general dentist. Monday to Friday, me and my team, we give our best to try to give best care for our patients, while on the weekends, I try to do the same for my family. Do you guys remember your first things? Our first things are something quite special to us, like your first car, or your first love, or maybe your first implant. I remember 2017, I placed my very first implant on a lower molar site on my CDA. It was Noble Biocare's replaced 5x10. And as a first timer, I remember being very, very scared about hitting that inferior alveolar nerve. Now, looking back, it was probably miles and miles away. Doing things for your first time can bring a lot of anxiety and fear, but it's only when you overcome that anxiety and fear, you can truly embrace it and grow from it. My journey as an implantologist only started not too long ago, and I feel like I was back in my little league days. Yeah. I would only swing my bat if the pitch was served right. But those pitches don't come very often, and therefore my batting average was pretty low, and I didn't get to hit any home runs. My patients were still happy to get the implants from me. They didn't want it to be referred out, but I felt that they still demanded better. Doing a traditional delayed protocol of extracting, grafting, waiting for a month, placing the implant, waiting another 4 to 6 months before a tooth goes on, that long treatment time sometimes could be a deal breaker for our patients. So I started to ask myself, how can we do better? How do I go from the little leagues to the major leagues, hitting these amazing home runs? Well, I knew what the answer was. It was immediate implant therapy. Immediate implant therapy has amazing benefits. When you combine extraction and implant placement at the same time, not only can it shorten the surgery time, the appointment time, the chair time, and also reduces the overall treatment time for our patients, it also serves to preserve the peri-implant tissue as much as it can. So immediate implant therapy was the way to go, and this was the home runs that I needed to hit. But I was very hesitant at first to incorporate it into my practice. And because I was simply scared. Being inexperienced in immediate implant therapy, in my head, I was very convinced that the immediate implant therapy had higher chances of failure. What if I can get the implant stability that I like? What if the implant position is all wrong? And what if it all just fails? Well, looking at the literature, I know this is not true. Even back in 1997, we know immediate implant heals predictably. And also there's lots of other evidences showing that there is similar survival rate versus immediate and delayed. So now I was out of excuse. I had to perform immediate implant therapy for my patients so I can serve them better. Now, before I jump in, I need some safety net. And so I rely on some of the tools out there to get my immediate implant successful and predictably. And there are two key tools and two clinical concepts that I utilize in my cases to make things work. And so I'll review these as we unpack our case today. Let's meet Lisa. Lisa is a 55-year-old healthy female. She works at a pharmacy right across from my office. She has been having a tooth problem, and her colleagues have referred her to me for her tooth problem. Her tooth 4 was broken. Previous dentists have placed a temporary restoration to reduce the sensitivity until a more definitive solution can be sought out. But due to COVID and her anxiety, it has been delayed multiple times until it finally got symptomatic. Her tooth 4 was broken palatally, subcrestally, and has started to get irreversible pulpitis. So patient had to get something done. After reviewing treatment options, risks, and benefits, we finally ultimately decided on implant as our treatment of choice. So as we gather her case records and plan her case, we start to utilize our first tool, which is the R2 gate. R2 gate is, in my opinion, one of the most accurate digital guided system. When we combine CT scan and a digital wax up together, it helps us figure out the best implant position. And it is a challenge during the immediate implant placement to figure out an implant position that can achieve A, the stability for the implant, and B, the support, the ideal support for the prosthetic. In Lisa's case, we place an implant into palatal root socket, grabbing the apical bone for stability and without compromising the final future prosthetic. Once the planning is finalized, the lab creates a surgical guide, which through it we can perform precise osteotomy preparation. So the extraction has to be done atraumatically as possible because it is important that we keep all the bony walls intact as much as we can. So elevation of the tooth must be done carefully, slowly, and methodically. Once the tooth is out, then surgical site is debrided with surgical curette. We place the surgical guide, verify its fit, and we go through our standard osteotomy sequence. Once the osteotomy is done, then we place the implant as planned. And as you can see, it's no problem gaining a great stability of 45 newtons per centimeters. And one of the reasons why we got a strong stability is because of our second tool, and it is the implant itself. There are many different designs and features of the implant out there, but there are certain features that helps us gain advantages in immediate implant therapy, and those are such as aggressive threads and self-tapping abilities. Now, these features that I look to get to give me a step up in my game, I have it in one system called Blue Diamond, and so I utilized 3.7 by 13 millimeters of blue diamond in Lisa's case to get that great strong initial stability. Once the implant is placed, it is time to do our depth control, which is one of the important part of immediate implant therapy. Now, when we do the depth control, we start to apply our first clinical concept, and that will be the zero bone loss concept by Dr. Linkevicius. Dr. Linkevicius claims that 4 millimeters of vertical soft tissue thickness above the implant platform is required to achieve stability of the crestal bone, thereby losing zero bone. So easy ways to achieve that is to place the platform 4 millimeters below, and because Lisa did not have any pre-existing recession, we would use the buccal gingiva as our final proposed gingival level and place the 4 millimeters below it. Now, it's easily verifiable by connecting a 4 millimeter of height healing abutment, which should sit flush to the level of the gums. Once the depth control is done, then now it's time to fill up our buccal jump gap. And this is where our second concept comes in, dual zone grafting concept. Now, dual zone grafting concept tells us that not only do we need to fill the allograft all to the bony crest, but above it towards the tissue zone. And it is because some of these allografts can be incorporated into the buccal tissue, helping it being maintained for long term. So we fill it up, And we use the sutures and periaquila to reduce the exposure of the graft, allowing the soft tissue to heal. 2 weeks later, we do our first recall. Sutures are removed and we can see a healthy tissue response. 6 weeks later, we see a full closure of the soft tissue around the healing abutment. And most importantly, if you can see, buccal contour is well maintained as part of the benefits of immediate implant therapy. Fast forward, 4 months later, implant is all integrated and we take a scan to make our final prosthetic. And again, look at that buccal contour. The lab is asked to make a custom titanium abutment with zirconia crown. And I asked the lab to anodize those abutments to minimize the show-through effect for best aesthetics. Now, it's important for us clinicians to check and double-check the emergence profile before loading the implant because unnecessary violation of biological width can lead down to unnecessary crestal bone loss. So implant is loaded and patient goes home with a lifelike implant restoration that I'm confident that it can last a very, very long time. So in Lisa's case, she came from symptomatic broken tooth to a lifelike implant restoration in just short of 4 months. Now this case could have been approached in a traditional delayed manner where we'll extract, graft, place the implant, and place the tooth in a span of 8 to 12 months. But doing it through immediate implant placement, patients get to enjoy the tooth in much shorter time, and also our peri-implant tissue has been preserved as well. Now, looking back at my Little League career, well, we can't talk baseball without talking about the legend called Babe Ruth. He was an amazing hitter in Major League Baseball, and he would hit 714 home runs in his career. When he was asked how he could hit so hard, he replied that never let the fear of striking out get in your way. If you're waiting for the right pitch to be served, then you will never hit those home runs. Sometimes we need to face our fear and just swing our bat, and we'll get those home runs. Now, I faced my fear, and I overcame it. And so in the last year, more than 90% of my implants I placed are immediate implant therapy. And I can proudly say I am serving my patients better. Now, I know there are some people out there who are still scared about immediate implant therapy, and I would like to extend my invite to you so that we can hit those home runs together and we can serve our patients better. We were once dental students, scared about a small little filling. But now we are implantologists. Let's hit those home runs together. Thank you for listening to my presentation today.
Those who are joining me live, we appreciate your support. And those who cannot, these presentations are 15 minutes long and will be available on our website, globalmegamind.com. Unlock your potential, test your mind. We are Megamind.